wearing the same outfit as in my picture. Just realized. Um, I'm Laura Barton. I'm one of the genetic counselors here at Moffitt. I've been here about 9 years. I did work in prenatal and cancer for a couple of years before coming to Moffitt, but now I am here till retirement is the plan. All right, so I'm going to talk a little bit about genetics and cancer, gastric cancer specifically. And I'm going to reference back a little bit to a couple of the different talks. So for instance, Dr. Palm just finished talking about radiation and talking about the fields and maybe affecting healthy tissue. That's a problem because that radiation really wrecks those DNA molecules. DNA is really stable, can hang around a really long time, unless you're hitting it with, were they photons? Is that what he called them? Yeah, that's bad for DNA. And DNA is really important in controlling how often our cells divide. And when cancer happens, it's always happening because genes are not working, because something has gone wrong. Now, for gastric cancer, only 3% of the time do we see that going wrong in the family, meaning there's some genetic inherited cause, some gene not working right, being passed down through the generations, giving higher odds for gastric and other cancers. We also see familial gastric cancer, and I'll talk in my next slide about what the difference is between inherited and familial. But most of the time, cancers, including gastric cancer, are what we consider random, meaning there wasn't anything that person was born with, nothing shared among the family that caused that cancer. It's not always random, right? If we know somebody is a very heavy drinker and they get cancer, well, that's not random. I know what caused it. The randomness comes in with what genes are changing, what mutations are happening as those cells are losing control and growing into a tumor. Now, familial versus inherited, I think people get a little bit like, well, things that are inherited are familial. And if I have something that's familial, it's probably being inherited. And yeah, but in cancer genetics, we call things that are familial. Basically, if I have a family that has more cancer than maybe they should, but there's not a genetic cause, that's where we call these familial cancers. So we know there's a higher risk. So for instance, in this family here, actually, I want to compare these two families. So we have these two different families here. This is my patient, what we call a proband in cancer genetics. And this is a young patient diagnosed with stomach cancer at 45. Her father had stomach cancer at 57 in this case, also with a history of alcohol and tobacco use. Now, in the inherited case, dad had cancer, but he was a lot younger and he didn't have those kind of environmental risk factors. Breast cancer in my patient's aunt, again, a younger age in the inherited family. Oh my God, what just happened? Jiminy Christmas. Oh, we're back. Okay. And in the familial case, a little bit more typical age of diagnosis for breast cancer. Now, I use age as a marker for the chance of something being inherited, because we know if somebody is born with that gene not working, they're coming out of the gate with something wrong. Now, they've got another copy of that gene from their other parent that's still working, that's still kind of picking up the slack. If and when that other working copy gets mutated, it stops working just during the course of someone's lifetime, we see those cancers developing. And that just doesn't take as long as the mutations that we see causing those more random types of cancer. So that's why we see those younger ages of diagnosis as a marker for something that could be inherited. And then finally, again, grandma here with her stomach cancer, much, much younger in the inherited family. Now, if I had this 45-year-old in my clinic sitting in front of me with either of these family histories, I'm going to offer testing because 45 is just kind of stupid young for a gastric cancer. But I'm not going to be too surprised over here if I don't find anything. Whereas here, I'm almost not expecting to find anything, but this is a pretty suspicious family history with all these young ages of diagnosis. Now, when I say find something, what does that mean? So typically now, the approach that we take in cancer genetics is what we call panel testing. We look at a bunch of genes all at once, kind of casting that wide net to see what, if any, gene might be at play in a family. There are types of cancers that are more or less associated with certain genes, so that certainly can guide some of our testing decisions. For instance, this hereditary diffuse gastric cancer, we pretty much always see diffuse gastric cancer with that. That's, like Dr. Pimiento said, doctors aren't very creative in their naming schemes. This CDH1 gene, though, this is actually a really interesting story right now, because in the past, before we did panel testing, so before, we'll say 2015, 2016 or so, we would only test people for CDH1 mutations if it was a family with 3 or more diffuse gastric cancers, or a gastric cancer under 50, and also a lobular breast cancer. So most breast cancers are ductal. The type of breast cancer we see with CDH1 is lobular. And so at that time, when we were only testing those families with a lot of gastric cancer, a lot of breast cancer, we were finding that these families had a really high chance for gastric cancer, up to 80%. Now, I test almost all of my patients for CDH1 mutations, especially in the breast cancer clinic. If a woman is having testing because she has a new breast cancer diagnosis and she's trying to decide about her surgery, we're going to test BRCA1 and 2, along with about 6 other genes, including CDH1. And so what we're finding is there's lots of families out there that have a CDH1 mutation and there's no gastric cancer. And it is really hard, and I think Dr. Pimienta will back me up, it's really hard to tell a patient, I think you should take out your stomach, even though no one in your family has ever had a gastric cancer. And we don't really have great numbers yet, I don't think, to say what really is the risk for gastric cancer. There are probably families with CDH1 that have that really, really high chance. And there are probably families that have a much more moderate chance. Now that's important because you'll see on my next slide here, the way we handle that, if someone has a CDH1 mutation and has that risk for gastric cancer, that particular type of gastric cancer, we recommend removing the stomach before they even have a chance to develop cancer, which is obviously not a minor procedure with Dr. Pimiento, but it's kind of a big impact. And again, it's hard to make that recommendation when I'm not even sure that person might have that high of a chance. So sometimes now patients will opt for random biopsies. And the reason we do that is if Dr. Mock puts a camera down your throat and looks at your stomach, he's not going to see anything if there's a diffuse gastric cancer kind of growing under that first layer that we can see. So those random biopsies would hope to find any sort of early cancer in these patients. And there's studies ongoing with this right now. Now, some of the other conditions, we don't see as high a chance for gastric cancer. But again, if I have a patient in front of me who has that young diagnosis and that kind of suspicious family history, I am probably not going to test for just 1 or 2 of these. We're going to do a panel. We're going to look at everything. And you can see the cancer types listed there are the other things we might see in a family that has one of these conditions. So depending on the gene at play, that tells us what we need to do. For the most part, we're going to recommend upper endoscopy. The difference is what age we're starting. For the most part, inherited cancer syndromes are adult onset conditions. We don't see cancers until people are adults, but there are exceptions here, especially with JPS and Putz-Jaeger's, where we do see those younger ages of diagnosis. So we do want to talk about testing kids. Now, I am going to take just a minute to indulge myself and talk about what genetic counseling is, because sometimes, a lot of times, I'm the first genetic counselor that somebody's met. They've never even heard of it. They don't know what genetic counseling is. And I think the best way to summarize what I do is I kind of translate information. I take complex information about genetics and cancer risk and what we need to do, and hopefully put it into language that my patients are easily understanding. I do have a master's degree. I actually have 2. I have one in bioethics from USF also, but most genetic counselors just have the one. And then there's, of course, different specialties in genetics. So again, my whole job is to help patients understand things, not just what their cancer risks might be, but also how would doing genetic testing impact them? You know, thinking about maybe you have 3 sisters and they're all very close. They've grown up together, obviously. They've, do all of the things together. They went to see Barbie last weekend together. They're all getting married the same weekend. It's all very together. And then they find out 2 of them have a mutation and 1 of them doesn't. And how does that impact their dynamic? And that's something a genetic counselor can help with. That mommy guilt of, oh, I gave my kid something that's going to cause them cancer. I can very logically explain, well, you didn't choose that chromosome and you had no way of knowing. And it's, you know, and now you can arm them with information. But it's really hard sometimes to help people adjust to that kind of information, especially when we're talking about our kids and something that could impact their health. Again, that age of diagnosis is going to be the biggest indicator for why a patient might come to see a genetic counselor. If there's been lots of different cancers or the same kind of cancer in a person, they might come see a genetic counselor. And really, if anybody's just curious about their risk, you know, I had a cancer, I don't think it's genetic, but what's the chance my daughter could have this cancer, or my son, or my sister? That's something that genetic counselors can help with as well. And then at Moffitt, just a quick plug, if you do want to see a genetic counselor here, website outside of Moffitt, there's a website called findageneticcounselor.com. I think a lot of times patients avoid seeing a genetic counselor or talking about genetics. Sometimes it's a misunderstanding. You know, I don't know how this will help me. I don't know how it will benefit me. And I think sometimes it's fear, right? I don't know what they're going to tell me. I think there's a kind of a conception in the public that genetics is your destiny. If I do your genetic testing for cancer risk, I'm going to tell you exactly what kind of cancer you're going to get, when you're going to get it, and what's going to happen with that. And that is not at all what I can do. What I can do is tell you, well, in these remaining years of your life, you have X% chance for these types of cancers. And we're going to recommend we do these screenings to hopefully have as early a diagnosis as possible. There are maybe one gene that I would say has a pretty much 100% chance for cancer. But other than that, it's really more about risks and understanding and hopefully trying to mitigate those as much as we can. And that's it.
Thank you, everybody. My name is Andrew. I'm one of the GI surgeons. I work with Dr. Pimiento. I'll be expanding a little bit on what Laura's just talking about.